Welcome back, everybody. And to those of you who are streaming, we know you're listening, and you may have heard all the fantastic questions the people in the audience here in Chicago have been asking. So, I'm just saying, we're looking to perhaps get some questions from you. That's all I'm saying. I'm also here to let you know that I'm sure many of you have clients who are stuck between the skilla of chronic pain and the Charybdis of addiction. And to help us navigate these murky waters, we are very fortunate to have Dr. Kenneth Candido. I'm sure many of you have read reports of his, and he is a pain management doctor who has been treating patients and who has been teaching students for many, many years. Dr. Kenneth Candido.
Thank you, Mr. Barish. Thank you, Chairman Brennan, and thanks to Arnie Rubin for extending this very gracious invitation. It's a privilege to be here this afternoon in front of all of you. And you're all very much aware of the opioid crisis or the opioid epidemic in the United States of America. It's not something which is new. Obviously, we've been inundated in the lay press with it. Opioids are an extremely stressful area of everyone's practice and for everyone's clients and everyone's patients. Injured workers are disproportionately affected by the opioid epidemic, and I'm going to go through some sobering statistics in just a moment. But when we're confronted with the modern day opioid epidemic, this is how I feel each and every day going to work. This is me, surrounded by federal regulations, local and state regulations, my patients, case managers, case workers, attorneys, and of course my office telling me that we are over prescribing opioids. We all have a duty to our clients and to our patients to do better, to manage pain absent the use of opioids in cases where that's acceptable and appropriate. Now, many of you, of course, are intimately aware that Vice President Al Gore invented the internet, and we also know that Mr. Gore also was the first to ever describe climate change, but many of you didn't know that he was also the first to describe the opioid epidemic. And we're going to go through a little bit of statistics in just a moment. And what is our actual problem with opioids? Opioids are wonderful for managing a variety of symptoms and a variety of conditions, primarily related to pain, but also to other conditions. They're very useful for sleep disturbances. They will help cure diarrhea, dysentery, angry, screaming children. And in the old days, they actually used to rub paregoric and other chemicals of opium, tincture of opium, on the gums of crying children. It's an actual truth. What is our problem? What is the epidemiology? Well, we have a burgeoning health crisis in this country that costs us about $120 billion per year in terms of the non-medical use of narcotics. Now, when I say non-medical use, obviously most of our patients are well-intended when they have injuries. Most of the physicians are well-intended when treating such patients, but we have a lot of individuals who take advantage of the largesse of physicians and who seek to use opioids for non-pain related conditions. And it's really a public health crisis, but by and large, prescription writing for narcotics is actually on the decline. I'm going to show you the latest statistics from the Center for Disease Control in Atlanta, Georgia. We also have another so-called epidemic that people aren't talking about as much, and that is chronic pain. Chronic pain affects almost 100 million Americans at a cost of almost $635 billion each and every year. And again, we have issues related to suicides. 2/3 of all suicide victims actually have chronic and unmitigated pain conditions. So this is a conundrum that physicians practice under and that you as their representatives and as their advocates have to contend with. We have pain. Pain leads to depression. Pain leads to addiction in many cases. Up to 25% of chronic pain patients consuming narcotics will actually become addicted. Very briefly, I was joking, obviously, about Vice President Gore. I got the utmost respect for him. He did not describe the opioid epidemic, and to my knowledge, I don't believe he invented the internet either. However, we have had an opioid epidemic in America since the 1860s. And so it's really not a new phenomenon. How did we get an opioid epidemic in the 1860s? Well, we had the American Civil War. And what preceded the American Civil War in 1804 was the isolation of morphine from opium. This happened in a very small little laboratory in the basement of a pharmacy in Austria by Frederick Serturner. A 21-year-old pharmacy assistant was tinkering around, and he isolated the morphine molecule from opium, a fascinating contribution to medicine. In 1853 in Scotland, Alexander Wood created the first hollow needle and syringe. So by the 1860s, with the explosion of the battle between the states, we had now a mechanism, a hollow needle and a syringe, to actually administer morphine to injured soldiers. In fact, morphine use was considered to be soldier's disease. There were about 400,000 soldiers, both on the north and on the south, who were addicted to morphine during the war and after the war. We called it soldier's disease. Interestingly, the Bayer Company, you've all heard of Bayer aspirin, right? The Bayer Company didn't make their fortune, their billions, selling aspirin until the 1900s. From about 1888 or so up until about 1913, they made billions of dollars manufacturing, selling, and distributing heroin. And so what happened? What happened after that? Well, we actually had the Harrison Narcotic Act of 1914. Some of you have heard of that. And that was by Representative Francis Burton Harrison from the great state of New York. He was a Democratic representative of the state. Interesting character, married 5 times, the former governor of the Philippines. Happened to die on the very same day that I was born in the very same hospital, although we never met. And Harrison actually said, you know, we've got Americans addicted in droves and using narcotics. Before 1914, you could walk into any 5 and dime store, any pharmacy, you could purchase cocaine, heroin, marijuana without a prescription, without a physician's requisition for you to get these medications. But Harrison said, hey, let's tax this. It makes sense. We see the same phenomenon occurring right now with medical marijuana, right? Why is there medical marijuana? Why is there legalization of marijuana? Well, the states derive great revenues from the distribution and taxation of these products. Our first pain clinic wasn't started until the 1930s, and then we had something called the World Health Organization stepladder approach for managing pain. So why were these laws created in this country? We have a huge epidemic. We've had it since the American Civil War. In 1875, the very first law in America was created against opium and against really the Chinese. Well, why? In 1849, the Chinese came here for the California gold rush. You've all heard of the San Francisco 49ers. So they had a gold rush in 49. In 1869, they completed the Transcontinental Railroad. Well, after the railroad was completed and there was no more gold to harvest, the Chinese stayed. And they created a huge squalor, right? There was prostitution, there was gambling, there were narcotics. There was human feces littering the street of San Francisco. Just like today, nothing's changed. The city is identical today to how it was in 1875. But the good citizens of San Francisco rallied around the mayor and said, please, we've got to stop this public scourge. We've got to eliminate these opium dens. And that was the first law in this country. And then, of course, the Harrison Act, also very, very noteworthy. Now, in 1886, the IRS created the Revenue Laboratory, which was the forerunner of ATF. You've all heard of ATF. Alcohol, tobacco, and firearms. What do these 3 disparate concepts have to do one with the other? What does alcohol have to do with tobacco or firearms? Well, these represent things that Americans are inherently addicted to. We're addicted to alcohol in massive quantities and numbers, tobacco, and firearms, right? In fact, I propose that they change the moniker ATF to FOFAT, because this is really what is the problem at the base of Americanism today in 2020. We are addicted to firearms, opioids, food, alcohol, and tobacco. Now, am I exaggerating this? Are Americans really predisposed to this? Absolutely. In fact, if you look at these 2 peasant farmers, Pablo Escobar from Colombia, worth as much as Michael Bloomberg. That's correct. At the time of his death in 1993, when he was shot on a roof by American agents trying to escape, he was worth $32 billion, but you translate that into present-day numbers, he's worth about $60 billion. El Chapo Guzman, worth about $14 or $15 billion. These were itinerant farmers, peasants, but they understood America's predisposition towards addiction. In 1906, you could open up the Sears Roebuck catalog and you could find and buy cocaine, marijuana, opium, heroin for pennies on the dollar, and syringes. In 1914, as I said, 1914, Francis Burton Harrison created the first law to tax the distribution, production, and sale of these products. In 1980, there were 2 regrettable articles that were published in scientific journals and peer-reviewed literature in this country. One stated that addiction was very rare in patients who were treated with narcotics. 40,000 hospitalized patients up in Massachusetts were retrospectively reviewed, meaning somebody pulled out a computer and looked at it and said, how many of these patients got addicted? Well, only 2. Then an article came out of New York City from Russell Portnoy and Kathleen Foley. These are big doctors that work at Memorial Sloan Kettering Hospital. They looked at a total of 38 patients. And again, found that these patients didn't get addicted when narcotics were used for legitimate purposes. The problem was, this was not really scientifically based. And the problem was that the huge pharma industry took these two papers and started to go around the country to mom and pop shops, doctors' offices, pain centers, surgeons' offices, and they started to say, you must use narcotics for your patients in pain because there's scientific evidence that proves that when narcotics are used legitimately, patients don't get addicted. Then we had the World Health Organization stepladder approach for managing pain. Unfortunately, my colleagues don't adhere to this, but this was actually the creation of Vittorio Ventafrida from Italy, and this is from Milan. It's a beautiful, beautiful paradigm, which basically tells you that we should never use narcotics for patients with mild pain. Unfortunately, my colleagues are oftentimes prescribing narcotics for injured workers or people with, even with legitimate medical conditions with low levels of pain. We should only use narcotics for more severe levels of pain, and then very judiciously, we should take great precautions when we prescribe narcotics for low levels of pain, and we should cut them off if they're not effective or if patients have side effects from their use. In 2007, the Purdue Pharma Company, you've all heard of them, they were owned by the Sackler family. Now, the Sackler family is one of the nation's richest families. They're located in Bristol, Connecticut, although they have homes all over the world. And it's interesting to me that 3 of their top executives were indicted for misbranding oxycodone. If you have clients who are taking oxycodone or OxyContin, you should understand that this chemical is going to disappear within the next several years. There are many, many lawsuits across the globe and mostly throughout the states. Even the city of Chicago is suing Purdue Pharma Manufacturing for mislabeling or misbranding this product. So these representatives of Purdue Pharma actually cost the company $634 million. That was about a quarter of their gross product or revenue for one single year. Just this past December, actually, they went out of business. They declared bankruptcy. However, the New York Times reported in December of 2019 that the Sackler family had hidden more than $10 billion in overseas accounts prior to declaring bankruptcy, untouchable money. In 2016, the Center for Disease Control in Atlanta, Georgia, made a certain statement. Now, some of you are familiar with this, but this has been bastardized not just by physicians, but by attorneys and by patients as well. And it basically stated that primary care physicians, family practitioners, internal medicine doctors ought not to be prescribing narcotics except for extenuating circumstances, cancer-related pain, end-of-life issues, and so forth, and only pain management physicians should do so, and they should limit the exposure of patients to 90 morphine milligram equivalents per day. It's a very, very low number, actually. And of course, this has been misused and misrepresented and misstated throughout time as being dogma. It's not dogma. It's a recommendation, and many, many of us don't adhere to it. In 2015, 1 out of 25 Americans received a prescription for a long-acting narcotic. There were almost as many prescriptions written for long-acting narcotics in this country throughout the entire year as there are Americans. This is probably the most sobering statistic that I'm going to tell you today. Please pay attention. We have 325 million Americans. We constitute 4.4% of the world's population of 7.2 billion people, and we consume 80% of all the narcotics in the world. In fact, Americans consume 99.9% of all the hydrocodone, Norco, Lortab, all the hydrocodone molecules in the entire world. Now, why this disparity? Do Americans have some type of genetic predisposition to pain? Why? Why are Americans feeling entitled? Why are your patients feeling entitled to the need for narcotics? How did we get there? Well, I'm going to show you how we got there. Each and every year, we have about 70,000 deaths in this country from overdoses of all types of medications, not just narcotics. Cocaine, benzodiazepines, methamphetamines, all kinds of medications, 70,000. Ponder that for a moment. If you filled up Soldier Field, it holds 61,000 patrons, 61,000 people. If you filled up the field, including the players and the vendors and all the ancillary people, and you destroyed it, you just bombed it once a year, that's how many people die from overdose deaths in this country each and every year. All takers, all comers, all medications. However, and this is important, you need to understand fundamentally, it's not physicians primarily or prescription narcotics that is killing people in 2019, 2020. What is killing people? Other synthetic narcotics. Now we know we have some history with the coronavirus in China, but China's been killing Americans long before the coronavirus because they make a product called fentanyl. Fentanyl is 100 times more potent than morphine, 30 times more potent than heroin, and it's made in China. And so those of you who may have issue with certain of the president's tactics and border control, I'm not here to talk at all about politics, to talk about the fact that we must do something about what's really killing Americans. It's not us, physicians, it's not even Purdue Pharma, and it's not even the patients themselves. Many of them unwillingly or unwittingly go out into the street to buy drugs off the street, and what they're getting is not what they think they're getting. They're not getting tablets of oxycodone, they're not even buying heroin, they're buying adulterated product which has now been infiltrated with fentanyl. Let's look at the overdose deaths related to any opioid. Again, that means whether it's a prescription drug, whether it's heroin, whether it's legitimate or illegitimate. We've got about 48,000 people dying each and every year. If you look at prescription writing, and this is important for individuals such as myself who are practitioners, and individuals such as yourselves who are advocates for your patients who are suffering, who've been injured. Prescription writing deaths are actually on the decline, and they have been on the decline since 2012. So why are patients still dying at an exponential rate? Because they're dying not because of their prescriptions per se, although that may be involved. They're dying as a result of prescription narcotics with other synthetic narcotics. Patients are buying, and even your clients, believe it or not, are buying narcotics on the street. They've been adulterated with fentanyl. The fentanyl is created in China. It's brought into this country. It's brought into this country, again, through the borders, through Canada and Mexico. It's made into tablets, and your patients are going out on the street. My patients are going out on the street, and they're buying these adulterated products. If you look at heroin, heroin deaths in this country are actually on the decline for the first time in many years. But heroin with other synthetic narcotics is exponentially escalating in the incidence of deaths. What about cocaine? Cocaine deaths totally flat, but cocaine and prescription or other synthetic narcotics on the rise. What about benzodiazepines? You're all familiar with drugs like Valium and Xanax. All your patients, many of my patients say, I need something for my anxiety, or I need something to sleep, give me some Xanax. Well, Xanax by itself or Valium by itself is not killing people. What's killing people are the combination of drugs like Xanax with other synthetic narcotics and prescriptions as well. Now what's more sobering still, we know that we've had an exponential rise in prescription writing until 2012, then we had a decline. And it continues to decline. It's gone down by 22% between 2014 and 2017. There's been a 22% reduction in narcotics prescribing by doctors. What we do see, though, are that patients are demanding amphetamines. Patients want to be wide awake. John Belushi died of a speedball. Heroin plus cocaine, right? He wanted to be wide awake while he felt the euphoric benefits of his heroin. People want to feel, they want to get high, but they don't want to go to sleep. And so we've had an 875% increase in prescription writing based on patient demands for mood-altering chemicals that raise their mood. So how do people die from narcotics? Most of the deaths are accidental, the dose is too high, or they have sleep apnea and they fall asleep and never wake up, or they're combining their medication with other prescription drugs, or they're drinking alcohol. We also know that many of the deaths are accidental. Okay, and we combine with illicit drugs. Homicide is very rare from narcotics, but suicide is not so rare with the use of narcotics. Now we have people who die who are not getting a legitimate prescription for medical use by altering the route of administration. What does that mean? They take their oxycodone tablets, they crush them, they snort them, they inject them. Those people are dying exponentially still. People with a legitimate prescription for narcotics who alter the route of administration. And some people just die by taking their medication normally and they have an arrhythmia or they die in their sleep due to some type of aberrant process of respiratory depression. That's who dies from opioids. And many of the individuals who die, the 18,000 who die from prescription narcotics every year, we have no idea how they died. We'll never know how they died, even after detailed autopsies and toxicology reports. So let's go back to this. Again, this is very important. This is from Vittorio Ventafrida from Milan, Italy. This is called the World Health Organization Stepladder Approach for Managing Pain. Your clients, those you advocate for, should not be taking any narcotics for a pain level below 4 out of 10. Nothing. If they have a pain level between, say, 5 and 7 out of 10, they should only use narcotics transiently or temporarily and then discontinue the use of their narcotics. And it's only for the most egregious, severe levels of pain, 8, 9, or 10 out of 10, that individuals ought to be using sustained release or long-term use of narcotics. Even there, we have to find alternatives to narcotic consumption. How did Americans become so addicted? Why does 4.4% of the world's population consume 80% of the prescription narcotics? I'd like to know. Anybody in the audience know why? Why do Americans, who constitute 4.4% of the 7.2 billion people in this world, why do we consume 80% of narcotics? Well, part of it is that physicians have gone from indiscriminately writing to avoiding. And how did physicians do that? Why did we get pushed into writing narcotics? Pharmaceutical industry is culpable to some degree. The lay press has inundated our patients, telling them that there's a right way and a wrong way to treat your pain. God help you if your doctor doesn't know how to pull out that prescription pad and write for those oxycodones, right? We talk about pain in militaristic terms, conquering pain, beating pain. When Bush Jr. was president, we declared a war on pain. You all know about how we win those social wars, the war on homelessness, on illiteracy, on obesity. We don't win those wars. We don't win the war on pain. Then Obama came in. Of course, he wanted to soften things. Let's not fight, guys. Let's do something a little bit better. Let's understand pain. Well, that didn't work either. And Americans have become the United States of America's Juana, right? Everybody wants to change how they feel. And I see this as something which portends a very unfavorable prognosis. Again, I'm not an addictionologist. I'm only talking from a pain perspective for your clients, for your patients, and my patients. And then Americans want to know, how do we get addicted, right? We want to know. What leads to this great addictive process where 25% of injured workers who consume narcotics will ultimately become drug addicts? But we don't want to do the work to solve addiction. We want a vaccination, right? Inject me once a month so I can continue the rampant, unmitigated use of my narcotics. Don't take my drugs away from me. And then we sensationalize those who have succumbed to addiction, right? We make heroes out of all these drug addicts. They're all heroes, right? Heath Ledger was a hero. Rush Limbaugh just got some Medal of Freedom, big drug addict. This other guy, now they're after over here, right? And then we sensationalize Michael Jackson. He was the king of pain, right? He was at his death taking Vicodin, Dilaudid, Xanax, Zoloft, Demerol, Visceral. I can't even tell you all the drugs he was taking until Conrad Murray, the cardiologist from Los Angeles, getting $100,000 a month to sit by his bedside and pump propofol in his veins so Michael could sleep. We made a hero out of Michael Jackson. Conrad Murray, of course, was on the phone talking to one of his many paramours in Houston and left Michael alone for about 2 hours and found him stiff as a board. We sensationalized Whitney Houston's death. We sensationalized Prince, right? Now, many of you know that Prince died in 2016. He was a big hero, great musician, well regarded. And of course, his last picture ever taken of Prince was the night before he died, right? He had just landed his plane urgently from a venue, right? He was overdosing on narcotics. And everyone said, well, Prince had a legitimate medical condition. He was an injured guy. He injured his hip. He had surgery. And so he's picking up his 180 oxycodone tablets here from Walgreens the day before he died. But he didn't die from oxycodone. He died from fentanyl, illegal fentanyl that he bought off the street, just like Tom Petty did. Fentanyl, which is 30 times more potent than heroin, which is 100 times more potent than morphine. They were buying these drugs because what they were getting from their doctors was insufficient for their needs. What is addiction, and what do we need to know about it? It's an aberrant behavior, including cravings, impaired control, compulsive use, right? We know what addiction is. Unfortunately, our patients don't present to our practices or your law offices with the big letter of A emblazoned on their chest. Yes, I'm a drug addict, but I want my medication. I did have a legitimate injury, right? I'm getting workman's compensation benefits. Give me my narcotics. No, they don't come to us that way. Because addiction is a disease of denial, D-E-N-I-A-L. Don't even notice I am lying. Denial. Patients will never tell you who they are. This is a room filled with, I don't know, a large number of individuals. By statistics, 10% of you have an addiction problem in this room right now. And none of you are standing up and saying, you're right, Dr. Candido, I'm an addict or I'm an alcoholic. But 10% of you in this room, statistically speaking, have an addiction problem. In the Workman's Comp arena, it's 25%. So who's at risk? There are biological, there are psychiatric, and there are social features. These are the people that scare me, right? They are individuals below the age of 45. I'm going forward, but I'd like to go backwards.
Left arrow?
Left, I'm doing left arrow, okay. One more.
Yeah, it gives you just, yeah.
Okay, I'm
just
sorry.
right.
So individuals below the age of 45 who smoke cigarettes and that they're men and they have a personal or family history, they're very high risk. But they can also have, I went too far. Sorry, folks. A psychiatric history and females who've been molested in adolescence, they have a very high likelihood of having an addictive process. Individuals who have been in multiple motor vehicle accidents. This should be a red flag to all of you when you're interviewing individuals in your stead. And we're supposed to categorize individuals in my practice. To recapitulate, we have a lot of overdose deaths in this country from any opioid, about 48,000. The vast majority of people who are dying are not dying from prescriptions now after 2012. They're dying from other synthetic narcotics. We've talked about these statistics, right? Heroin not killing as many people as it used to, but heroin mixed with other synthetic narcotics, primarily fentanyl, that's what's killing individuals. This is really important. And you as attorneys, when you go out and counsel your clients and advocate for your clients, if you find out that they're taking Xanax or Valium, this is a big red flag, because there's really no other condition that's killing individuals as exponentially as the consumption of benzodiazepines and opioids for legitimate medical purposes. Now, I told you, China is not only killing us with the coronavirus, it's killing us with fentanyl. This is where the narcotic is being made. It comes as a powder, it goes to Los Angeles and other places in this country, but it gets into this country through Canada and Mexico. Again, not a political statement about border control. These drugs that are killing Americans exponentially are coming through Canada and through Mexico. And how are they getting to Americans? Well, they're made into pills. This is a pill mill. This is actually one of the presses that was confiscated by the DEA in Los Angeles. Okay, you see that on the left screen? And these are what the pills look like. They look exactly like legitimate oxycodone tablets. They're being sold on the street for $70, $80, $100 a pill, but they're laced with the adulterant fentanyl, and they're killing people exponentially. Why fentanyl? Why is fentanyl so powerful? Because it just is. It's 80 to 100 times more powerful than morphine, 30 times more powerful than heroin. Right? This is from the U.S. Customs and Border Patrol. Last year, they've seized 650 pounds of fentanyl and methamphetamine at the Canadian border. Those of you who know James McDonald, he's the Assistant Secretary for declaring weapons of mass destruction. In February last year, he declared fentanyl as a weapon of mass destruction. Now, how is fentanyl a weapon of mass destruction? Those of you old enough in this audience to remember what happened in Moscow in 2002, there was a siege. There were 900 theater goers assembled at a theater in Moscow. 40 Chechen rebels came into the theater demanding that the Russian government release other hostages, political prisoners, and so forth. And they held all these 900 theater goers hostage. The Spetsnaz, you've heard of Spetsnaz. It's like a hybrid between our FBI and our mafia, because they kill a lot of people, right? And so what the Spetsnaz did, they didn't know what to do. They had a hostage situation. They called the FBI in America and said, how do you get these people liberated from this theater? They called Theater Stanley. I was very good friends with Ted. Ted was a professor of pharmacology and anesthesia at the University of Utah School of Medicine. His nickname was Dr. Fentanyl because he created many of the products which are used in operating rooms across the globe. He actually created a product, carfentanil and low fentanyl. You put one drop on the head of a pin and you shoot it at a charging rhinoceros from 40 yards away. You stop it dead in its track. The rhinoceros is not dead, it just gets anesthetized, narcotized. And Theodore Stanley said, you got to put fentanyl in the ventilation system. But of course the rebels had gas masks, so many of them escaped what happened, and 130 theater goers were killed from respiratory depression. Fentanyl is a weapon of mass destruction. So where did I get my information from? It comes from the Center for Disease Control. This is available to all of you every 3 years or so. They update it, so the most recent iteration of this was 2017. They will tell you about prescribing habits, drug use, non-fatal overdoses, and drug overdoses. I encourage all of you to seek this information if you have an interest in this topic from the United States Center for Disease Control. Now, physicians are not exonerated from the opioid epidemic. We have some bad actors as well. Tesher Martin, 83-year-old pill pusher from New York City, killed a couple of people, including including a 26-year-old guy from Staten Island. In a 5-year period, Tesher Martin wrote 2.2 million narcotics tablets of oxycodone. He's going to jail for 20 years. He'll never get out. We're also subject to some of the consequences of the opioid epidemic. This is a very tragic story that happened to a great pain physician practicing by South Bend, Indiana, Todd Graham. Now, Todd Graham had a patient come in, workers' comp patient came into his office 3 years ago, right? The patient had pain. For 15 years, the patient was taking narcotics. And then the patient's doctor said, I'm not going to give you narcotics any longer, go see Dr. Graham. Well, Dr. Graham said, you know what, I don't use narcotics for these benign conditions. I can't give you narcotics tablets. The husband was irate. He said, my wife's going to have a withdrawal. And Graham said, I'm sorry, we don't use narcotics for these benign conditions. A lesson learned. Graham goes out to his car at lunchtime. The husband's waiting in the parking lot, shoots Dr. Graham twice in the back of the head and kills Dr. Graham, and then shot himself. So in conclusion, I think I'm about a minute over, so I'm sorry. Prescription opioids were formerly driving this process, but now they're on the decline since 2012. This understates the fact that physicians since 2012 have gotten the message. We're no longer responsible. Yes, sir.
Yeah, I have a quick question for you.
Wait,
Okay. There's been a 22% decrease in opioid prescriptions, as I already mentioned, between 2013 and 2017. We're writing less, yes.
All right, where do you see the role of medical marijuana transitioning? Because, I mean, that's our reality.
Well, medical marijuana has been demonstrated in some studies. I don't think the quality of the studies is very robust, to be opioid sparing or opioid reducing in terms of patients requiring less narcotics. The jury is still out as to whether the use of medical marijuana will supplant and eliminate the ongoing use of narcotics. My overall conclusions, and I thank you for allowing me these extra minute or so, identify high-risk patients. That's my job. But when you send people to me, you can be sure that I've got strategies in place to identify high-risk patients. Do the exam, find out what the treatment goals are, and they do not include narcotics in 2020 in the vast majority of individuals. Educate patients. Do not use long-acting narcotics or potent narcotics except in very, very serious intractable cases. And remember that even though we have drug overdose as a large, burgeoning, ongoing problem, it's not prescription narcotics that are killing patients exponentially, it's other synthetic narcotics. And so if you have any interest in contacting me, by all means you may do so. My information is up here on the screen, and I'll be happy to take any of your questions at the completion of this session. Thank you for your time and attention. It's been a privilege to speak to you here today. Thank you so very much.
Dr. Candido, thank you very much for the presentation. And I am impressed that you got through all that material in 30 minutes. For a second, I was like checking my pulse and wondering, did I eat something that I wasn't supposed to eat?
It was only 960 slides.
It's a dosing issue. You know, we have to work on that. Thank you, Dr. Candido. We are now going to deal with, I know you guys are